Distinguished colleagues, I am Sanskar Virmani from Tashkent State Medical University, and I am honored to present our research titled Determining the Effects of Physical Activity on Ischemic Heart Disease. In the management of chronic coronary syndromes, particularly stable angina pectoris, we face a critical failure point in outpatient risk stratification, the reliance on self-reported patient data. Our primary objective in this prospective cohort study was to quantify the cognitive dissonance between a patient's subjective recall of physical activity and their objectively measured ischemic threshold. However, we evaluated the clinical efficacy of a dynamically titrated ml guided rehabilitation intervention. We evaluated a cohort of 183 urban and rural patients presenting with functional class 2 and 3 of stable angina pectoris. Our baseline assessments exposed a profound and clinically dangerous cognitive dissonance. Utilizing the ODA 23 plus psychometric questionnaire, nearly 65% of our male patients subjectively rated their physical activity as medium or high. However, when we bypassed subjective recall and subjected these patients to clinical cycle ergometry to map their exact external workload, the objective data was striking. 80% of urban patients and over 88% of rural women demonstrated low or very low objective physical tolerance. Patient diaries further confirmed severe systemic hypodynamia marked by extreme hypersomnolence, with urban men and rural women averaging over 11 hours of sleep daily. This confirms that unverified subjective service critically masks the true cardiovascular risk profile. To combat this sedentary behavior, we implemented a 6-month personalized physical activity regimen. Rather than offering passive medical advice, exertion was dynamically monitored and titrated via our mobile application, the Health Run app. We strictly utilized safe heart rate limits derived from each patient's baseline cycle ergometry. The follow up hemodynamic data demonstrated highly significant improvements. As illustrated in this chart, objective work volume capacity surge across all cohorts. We observed a 1.6 to 1.8 fold increase in the urban cohorts and a 1.7 to 1.9 fold increase in the rural cohorts, achieving statistical significance p-value less than 0.01. Most critically, from a high equity perspective, this intervention successfully extended the duration of safely tolerated exertion and markedly attenuated the arrhythmogenic burden. During follow-up cycle ergometry, the occurrence of load-induced pathological markers decreased drastically. We observed highly significant objective clinical reductions in ischemic ST segment shifts, as modeled on this poster, as well as marked suppression of both supraventricular and ventricular extrasystoles, yielding a p-value of less than 0.001. In conclusion, our data establishes a definitive clinical mandate. We must shift away from dangerously inadequate subjective recall and prioritize objective modalities such as cycle ergometry to determine true ischemic thresholds. Furthermore, aggressively monitored ml guided cardiac rehabilitation successfully reverses severe hypodynamia and safely mitigates life threatening arrhythmias in the ischemic heart disease population. Thank you for your time and attention.